Okay, so let's come back to the PALS 2010, and this one's going to be about drugs, the various drugs that we use in PALS. And here they are, all the drugs that they talk about, and they are presented in a great table in the article from Circulation 2010, Kleinman et al., Part 14, PALS. So I'll try and get through all of these in one video, but if not, we'll break it up into two. Now, most of these drugs are going to be weight-based, but you're not going to take your pulseless, lifeless child and put them on a scale, so you do have to estimate their weight, and we know that we pretty much suck at guessing weights. We're not carnies. Damn it, Jim, I'm a doctor, not a carny. So we can't really guess the weights, but we do have those weight-based tapes, which you can lay down next to the child and then see into what section they fall into, and that will give you an estimate of the weight. And now, unfortunately, McDonald's and everything has turned our children from these cute little things into more round, obese children. And so we don't really know what this is going to do, because if you were to just use their weight, you would probably overdose the medication. And using the tape in an obese child would underdose it. So the true dose is probably somewhere in between, but who knows where that is. And so we do the best we can with what we have, so I'd probably go with the tape. Their recommendation actually is to use the patient's, despite their body habitus, to use the patient's actual body weight or the tape for pre-calculated doses. So the first drug they talk about is adenosine, and what that does is it blocks the AV node temporarily, and so can break any of these reentrant circuits that are there. And the dose is 0.1 mg per kg for the first dose and double it for the second one, and you max out at the adult doses, which is 6 and 12. Now this thing has a very, very, very short half-life, so you want to give it in the IV that's closest to the body and flush it in fast. And what you'll see is that the heart rate's going to slow down, and it actually looks like it's going to stop. If you ever give it to patients who are awake, they're going to feel horrible. They're going to feel like they're flushed and a heavy chest pressure, so warn them. But don't worry, it's only temporary. And the next drug we'll talk about is amiodarone, and this thing plays with the intervals. So the first thing that it does is it slows down AV conduction. So you'll see a lengthening of the PR. It also prolongs the AV refractory period and lengthens the QT. And it also slows down ventricular conduction. So you'll see the QRS widen. And it can also cause hypotension. So if you're giving it to someone who's got a perfusing rhythm already, you want to give it slowly. And you'd probably want to consult with the pediatric cardiologist to make sure that's the right thing to do. Now, if you're giving it to someone who is pulseless, maybe pulseless VTAC or VFib, you're going to give that as a bolus. And if the patient has a prolonged QT already, be careful, because this is going to prolong it further, and you can push this person into torsade. So if they're on an amiodarone drip, watch that QT. Make sure that doesn't get wider. If it does widen by 50%, you're going to have to slow that amiodarone drip down or perhaps even stop it. And the dose is 5 milligrams per kilogram, and you could repeat this dose twice. The maximum you're going to want to give is 15 milligrams per kilogram, and the max dose, just like adults, that's where we're going to stop it, is 300 milligrams. The next drug we'll discuss is atropine. So the parasympathetic system is responsible for kind of putting the brakes on the SA node and the AV node, so slowing those down. So atropine, being a parasympatholytic, takes your foot off the brakes, which then has the effect of removing the slowing or allowing these things to speed up. And the dose here is 0.02 milligrams per kilogram or 20 micrograms per kilo. And there's a minimum dose. You want to give at least 0.1 milligrams. And we'll max out again at the adult dose at half a milligram. Now, the reason why you have a minimum dose is because at doses lower than this, it can have a paradoxical effect. Instead of speeding things up, it could make things go slower. The next one we're going to talk about is calcium, and that comes in two varieties, calcium chloride and calcium gluconate. Now, calcium chloride tends to have more ionized calcium, but because of this, it can be painful to administer as it's sclerotic to the veins. Now, the calcium gluconate, you can give that in a peripheral IV. Now, they recommend do not give this. Do not give it unless you have a clear indication, and the indications are hypocalcemia, a calcium channel blocker overdose, hyperkalemia, or hypermagnesemia. And the dose is 20 milligrams per kilogram with a max of 2 grams. And now epinephrine, and the dose for that here is 0.1 milligram per kilogram if you're going to give it in the IV with a max of a gram. And remember, if we give it in the endotracheal tube, we want to multiply it by 10. Give 10 times a dose, so 0.1 milligrams per kilogram. And the max here is 2.5, not 25. I put that decimal point there to emphasize it. It's 2.5 milligrams. Now the reason, remember that we multiplied this by 10, is that at the lower doses you're going to have more beta-2 agonist effect, which is going to cause a vasodilatation. And that's not what we want. We want this vasoconstrictor effect that comes from alpha agonist effect, because that's going to raise the blood pressure, increase coronary perfusion pressure, and increase blood flow to the coronary arteries, therefore increasing the possibility that we're going to get return of spontaneous circulation. So we don't want to go too low on the dose. Remember, ET tube, we're going to increase it. So the next drug is glucose. Now remember that these infants and kids, they get hypoglycemic very easily because they have very small glycogen stores, and they also have a high metabolic rate. So remember, check a blood sugar. And if it's low, especially if it's less than 60 or maybe 50, then you want to treat it. And now there's a great way to know the dose. Well, the dose is actually 0.5 to 1 milligram per kilo. But the trick is that glucose comes in so many different solutions. It comes in D5, D25, D10. So how do you know what to give? Now this is where you remember the rules of 50. And what that rule says is you have to look at the 3 different categories: neonates, infants and children, and kid really means like adolescents. So you want to give the neonate 5 to 10 mLs per kg of D10W. Now look, 10 times 5 equals 50. All right, let's look at the infants. You want to give them 2 to 4 milliliters, I should say, not milligrams, per kg of D25. 25 times 2 equals 50. So again, remember, it's milliliters per kg. I misspoke earlier, and I've corrected it now, milliliters per kg. Now for the adolescents, you want to give 1 to 2 milliliters per kg of D50. So 50 times 1 equals 50. So that's the rule of 50s in how you want to give glucose to kids. And you could even say, well, let's worry only when the glucose drops below 50. That's when we'll call them hypoglycemic. Okay, so let's stop here. We covered a bunch of the drugs, and we'll cover the next bunch in the next video.